We have Dr. Palladini coming from all the way from Pavia, one of really the world's experts in many types of amyloidosis, but particularly therapy of AL amyloidosis, and we're so happy that he's going to be kicking off the speakers with his talk about initial treatment. Thank you.
Thank you, Jeff. Thank you for setting this up and for inviting me to this symposium today. I will briefly introduce AL amyloidosis. As you all know, this is caused by a plasma cell clone that qualifies for multiple myeloma in less than 50% of cases. So it's quite a small plasma cell clone that produces a toxic light chain that undergoes conformational changes that make it able to deposit in tissues in the form of amyloid deposits. This light chain also exerts kind of a direct toxicity on the organs that can be involved by the disease. The two most commonly involved organs are the heart and the kidney, as you can see here from the Pavia series, followed by the soft tissues, liver, and autonomic and peripheral nervous system. Of course, the clinical presentation and the severity of the disease is strictly dependent on the type and severity of organ involvement. And luckily, we have powerful tools to evaluate the severity of this disease. We have staging systems that were first proposed by the Mayo Clinic by Dr. Dispensieri in 2004. And the first staging system that was proposed is a whole cardiac staging system based on NT-proBNP and troponin. And as you can see here, based on very high concentration of NT-proBNP and elevated troponin, we can identify approximately 20% of patients who are extremely sick and bound to a very poor outcome in the first year. 80% of these patients die in the first year after diagnosis, while there are patients without cardiac involvement with normal biomarkers who have a slow decay, and 70% of them are alive after 10 years. The clonal markers are also important, and the concentration of the free light chain has been added to the staging system. And as you can see here, the discriminating ability of the staging system is very good. This is not only a marker of the bulk of the disease, but this is actually the causing agent in organ dysfunction. And we and others have shown that approximately 20% of patients who have a very low FLC level, we talk about a DFLC of less than 50 milligrams per liter, have a relatively good outcome, a very good outcome compared to other patients, and are less likely to have heart involvement. So the free light chain concentration and heart involvement with biomarkers are strictly connected. And also it is quite easy to stratify the severity of renal involvement. This is based on proteinuria and estimated glomerular filtration rate. Patients who have a relatively low proteinuria and preserved renal function have almost completely reversible renal damage, renal dysfunction. And their progression through dialysis, if they are diagnosed early, is very low, 1% at 2 years. So what we can see here is that there are patients who are extremely sick when they are diagnosed, and there are patients whose disease is almost reversible or irreversible in the majority of cases if they are diagnosed early. So the balance that we have to do in treating these patients is of being quick versus being delicate, being soft with them according to the severity of the disease. And of course, these patients, while they are being treated, needs a very intensive supportive care that in some instances can be literally intensive care support. So the aim of our treatment is the plasma cell clone that we have met at the beginning of this talk. And we are now besieging the plasma cells with many effective drugs that come from the experience of in multiple myeloma. We have alkylating agents, proteasome inhibitors, IMiDs, dexamethasone, and now immunotherapy, and stem cell transplant that can be sequentially or simultaneously combined to kill the plasma cell. And we assess the effect of this by looking at the reduction of the free light chain that is toxic to these patients. And we do so in order to improve organ dysfunction. If we are quick enough and effective enough, we can actually, in many instances, improve the organ dysfunction of these patients. And we can make sure quite early that this is happening by looking at decreases in markers, in biochemical markers of organ dysfunction. And this process is tightly connected to and directly translates in an improvement of survival, of the outcome of our patients. You see that less than 20% of patients who do not respond to upfront treatment in our series in Pavia, this is more than 1,000 patients, are alive at 5 years. But this increases to almost 60% and to more than 70% if patients get to any hematologic or organ response. And we have criteria to assess hematologic and organ response that come through a huge international effort over the years that we have done, and that, of course, is not completed. But what we can see here is that, talking about hematologic response, there is, again, a tight connection between the level of the residual free light chain and survival. This is not like in multiple myeloma. This is not consensus criteria. This is validated, and each little reduction in the free light chain that you can get actually translates into an improvement of survival. And also we can ask the organs if the hematologic response that we get is enough for them to improve. And we can follow cardiac and renal response with biomarkers. And this is, again, reduction of these biomarkers is, again, connected tightly to the improvement of survival in these patients. But I said that this is not stopping. This is a continuous effort. And recently, the Mayo Clinic group, Dr. Mukhtar, showed that we are actually able to grade also organ response based on biomarker. And they also validated the criteria of liver response based on alkaline phosphatase. So we have tools to follow closely our patients. And combining these tools, we observed that there is a very tight correlation between the degree of hematologic response and organ response. We know very well, unfortunately, that there are patients who attain a very good or a complete response. This should be the target of our treatment, but still have residual organ dysfunction. Patients who get only partial response have only a less than 20% chance to get to organ response. This increases up to 55% in our whole series if they get to complete response. But we have very preliminary data on 70 patients who were assessed with next generation flow, who are in amyloid complete response plus MRD negativity by NGF. And so far, this is a small series, but 90% of them attained also organ response. And this, again, emphasizes, I think, the need that we have to try to reduce quickly and effectively the amyloid light chain to improve the outcome for our patients. And we are borrowing tools from multiple myeloma to do so. There are two large published series of stem cell transplant in AL amyloidosis. The most recent one from the Mayo Clinic, and a great experience from the Boston University group. And you see that the rate of good quality hematologic response, that is VGPR plus complete response, is extremely high with stem cell transplant and increased over time with better patient selection. This improvement in patient selection also reduced significantly, this is the Mayo Clinic experience, but it is reproduced by many other centers, the rate of early mortality you can see here, and this translated into an increase in overall survival. They found that the use of high dose 200 melphalan as a conditioning is also associated with a better outcome, and this is not only due to a patient selection, but this is actually an independent variable in multivariable analysis when it is added on variables of severity of the disease. This improvement over time was not seen or was less pronounced in a patient with heart involvement. You see that in this paper of 2015, published in 2015, there was no improvement actually. And again, the Mayo Clinic investigators very elegantly showed that almost all the early mortalities segregate in patients who have a high biomarker concentration at diagnosis. And of course, these patients with high NT-proBNP and high cardiac troponin are not good candidates for stem cell transplant. And here I have summarized the criteria that are actually currently used at most of the amyloid centers worldwide. And you see that many centers have included the concentration of the cardiac biomarkers as eligibility criteria for transplantation. It has been shown that induction therapy preceding stem cell transplantation is useful, particularly in patients. There is approximately 50% of patients with AL amyloidosis who present with a bone marrow infiltrate of greater than 10% plasma cells. So they have a higher response rate. But more recent data showed that this also translates in a survival benefit when induction is done with newer drugs, particularly bortezomib. And maybe, as this editorial by Joseph Michael proposed, that this is just because you can start treatment quicker to immediately stop the process of amyloid toxicity and deposition in these patients while you set up the procedures for stem cell transplant. And indeed, in this small, very nice study from the London and Heidelberg group, you see that pre-transplant therapy with a stem cell sparing chemotherapy actually can improve organ dysfunction and render patients who at the beginning were not eligible for transplantation transplant candidates. And patients can be transplanted second line in a way if they become eligible, and or even as a consolidation. And finally, bortezomib-based treatment can be used also as an adjuvant approach after stem cell transplant. And overall, Dr. Comenzo and Dr. Landau showed that this sequential approach, adding bortezomib post-transplant, is able to increase the complete response rate to almost 60%. But unfortunately, only a minority of patients with stem cell transplant, with AL amyloidosis are candidates for stem cell transplant. So the bulk of our patients is treated with non-transplant chemotherapy. And in these slides, I summarized the currently available regimens. This is just a summary of the larger studies that are basically grounded on the combination of melphalan, dexamethasone, or cyclophosphamide and dexamethasone with the addition of IMiDs and bortezomib. You see that these studies are not easily comparable due to the different proportion of patients with advanced disease. And the proportion of patients with advanced disease translates in differences in both the hematologic and organ response rates, as well as survival. Overall, we can see that with these combinations, the hematologic response rates can range from 40 to almost 80% depending basically on the severity of the disease, and this also reflects in differences in survival. So we have very few data to say which is the best non-transplant treatment in these patients, also because we lack comparative studies in this setting. But we thought that bortezomib could be kind of a silver bullet for these patients, because we thought that we could use bortezomib to direct against the plasma cell the toxicity that the amyloid light chain actually exerts. And indeed, if you look at the amyloid plasma cell at electron microscopy, you see that the mitochondria in these plasma cells have a perinuclear placing compared to multiple myeloma plasma cells. And even if I like the AL plasma cells, I think they are nicer, still they say that this is an indicator of stress. So we engineered a line of non-secretory mouse plasmacytoma to produce either myeloma or amyloid light chains, and we saw that the production of amyloid light chain, but this cell line reduced the lifespan of the plasma cells, and also increased the sensitivity to proteasome inhibitors. We have run and concluded a phase 3 trial comparing MDEX versus MDEX with the addition of bortezomib, and we observed that the overall response rate is significantly higher at 3 months with bortezomib MDEX versus MDEX, particularly due to more profound responses. There was a higher rate of VGPR. This translates in a longer progression-free survival. And after 1 year of observation, also we were able to observe quite a significant difference in overall survival as well. Other data that can help us in deciding which therapy to use in non-transplant candidates can come from the IFISH studies of the amyloid plasma cells. These studies were pioneered by the Heidelberg group. They observed that patients who harbor the translocation 1114, that is approximately 50% of patients with AL amyloidosis, actually have a lower response rate and a shorter survival with bortezomib-based combinations that do not include melphalan. While gain of 1q21 is associated with poorer outcome for patients who are treated with melphalan dexamethasone. So one could argue again that the combination of bortezomib, melphalan, dexamethasone could be an option to overcome both this poor effect of chromosomal abnormalities in these patients. One more data that we have is that we observed a slightly longer time to second-line treatment in patients who got both bortezomib and melphalan as upfront therapy. And this was independent of all the other variables that were observed affecting time to second-line therapy in our patient population. So overall, a wide consensus a review has been published recently involving almost all the amyloid centers worldwide, and we could give some indications on the selection of non-transplant treatment upfront in AL amyloidosis. BMDEX could be considered upfront, but CyBorD has the advantages of being stem cell sparing and can be preferred in patients with renal failure. So if you have a patient who you think has a potentially reversible contraindication to stem cell transplant, you should prefer CyBorD over BMDEX, and MDEX can be still a viable option in patients with neuropathy or fibrotic lung disease that are contraindication to the use of bortezomib. And what to do with high-risk patients? Basically, we use the same regimens. You have two options. You can use these same drugs, these same regimens at a reduced dose, or you can be intensive with supportive therapy. You can admit these patients with very advanced disease to intensive care unit and use upfront not reduced, not attenuated non-transplant chemotherapy in these patients. And Dr. Wechalecker showed that achieving a response in these very disadvantaged patients, particularly if this is good quality response that is achieved within the first 30 days after diagnosis, is actually able to significantly improve the outcomes of these patients. So definitely, these patients should be treated and should be treated early with rapidly acting regimens. We have new agents that are being considered. I will present here the ones on which we have some clinical data. One is the second generation proteasome inhibitor ixazomib. In this phase 2 trial, the drug was able to produce a hematologic response rate in more than 50% of patients, and it was particularly effective in proteasome inhibitor naive patients. And we are all waiting the results of the phase 3 trial that is ongoing in relapsed refractory patients, comparing ixazomib with physician's best choice. However, lenalidomide is the backbone, I think, of treatment of relapsed refractory patients. Again, there are many studies, and this is a selection of studies that were published in this second line, in this pre-treated setting. You can use lenalidomide with dexamethasone and with cyclophosphamide. What you can see here, and it is remarkable, I think, that particularly in more recent studies, when patients had more option at the beginning, these patients that were included in these studies were treated with really all available approaches, and despite this, a considerable proportion of hematologic responses was obtained, ranging from 40 to 60%, despite they were heavily pretreated, including transplant, bortezomib in many instances, 100% in one study, and melphalan. Pomalidomide has been also tested by the Boston group, by the Mayo Clinic, and by ourselves. This is our data that were published later. The hematologic response in these patients who were all exposed to alkylators and bortezomib and refractory to the last line of therapy was quite high, overall 68%. And almost all patients had some reduction of the free light chain. Responses were quick and translated in a survival advantage, also in these very heavily pretreated patients. Lastly, one more option that we have is bendamustine. There are two studies, one published by Dr. Milani from our group and one by the NAC in London. And we both observed that there is some response to bendamustine that is particularly interesting when this drug is combined with rituximab in patients with IgM, AL, amyloidosis. And again, you can see in the Italian and German study and in the British study that there was a survival advantage in patients who responded to this drug. Overall, now we know quite a lot of our target. We have tools to follow the disease, to diagnose the disease early, which is extremely important because we cannot wait to see patients so unfit to be treated quickly and effectively. But still, when we see there's patients with very advanced disease, we must treat them because they can improve, as Dr. Wechalecker showed very clearly. And we have many weapons, more than the ones that I have reviewed with you today, that I think should be combined simultaneously and sequentially in order to get the highest possible response rate. I would like to thank you for your attention and all my co-workers in the Pavia Amyloid Center. Thank you very much.
Thank you. Thank you.